Herkese günaydın. 16. Türk Hepato Pankreato Bilier Cerrahi Kongresi'ne hoş geldiniz. Kongre öncesi kurslarımızın başlatıyoruz bu kursumuzla birlikte. Paralel 3 salonda yürüyecek kurslar. Oldukça ilginç konular ve değerli konuşmacılar var. Bu kursumuzun ismi Minimal İnvaziv Hepato Pankreato Bilier Cerrahi'de video oturumu nasıl yapıyorum? Daha çok teknik ağırlıklı gidilecek. Çok değerli yerli ve yabancı konuşmacılarımız var. Ben de kursumuz oldukça dolu olduğu için çok da sözü uzatmadan ilk konuşmacımızı tanıtarak kendisini kürsüye davet etmek istiyorum. Profesör Thilo Hackert ilk konuşmacımız. Konusu Kanıta Dayalı Laparoskopik Robotik Pankreatikoduodenektomi. Profesör Hackert, Hamburg Üniversite Kliniğinde şu anda klinik direktörü olarak görev yapmakta. Kendisinden bu ilginç konuşmayı dinlemek istiyoruz. Thank you very much, Professor Hackert, for joining us.
Speaker in your course today of the Congress, and the topic of my talk is laparoscopic and robotic evidence-based pancreatic surgery or pancreatikoduodenektomy. And this is a little kind of a problem because there's not so much evidence at the moment, but I will show you as soon as we get started. Why do we talk about this? We talk about this because the robot is rising. These are data from the US, you can see. These are data during the last 10 years, and the proportion of robotic procedures has increased for approximately 10-fold in all of these procedures. And what we see here is that this is still continuing, and we can see what kind of procedures were done with the robot here. I just struggle a little bit with these things to go for. Now we see it. You can see the robot is rising, laparoscopic is stable, but the open surgeries are a little bit decreasing, and this is still going on. So we have to deal with this. And when you look at this, you see that also a lot of non-senseful operations are done with a robot. From my point of view, you don't need a robot for any hernia repair or for cholecystectomies. You need a robot for the complex resections. And of course, the complex resections are also rising. For the pancreas in the US, it was about 4-fold increase over this 10-year period. And in the meantime, this is probably a 10-fold, 12-fold, 15-fold increase that is happening. When you look at the data coming out, they seem to be very good for oncological robotic pancreas surgery, but I would ask you to be careful with this because this is clearly a selection effect. You operate the easy cases with a robot, you operate the difficult cases open as you have done before, and therefore oncologically the easy cases are the small tumors, they have a better prognosis, so this is not evidence-based. What are the aspects of the robotic and laparoscopic surgery? There's the patient, there is the surgeon, there is the surgical outcome, oncological outcome, and of course, last not least, the money, especially for the robot. I want to start with the patient. What is the evidence we have? We do have evidence for the laparoscopic Whipple. This is the largest randomized controlled trial published some years ago from China. 300 patients in each of the groups were randomized for an open or a laparoscopic Whipple. You can see that these patients were balanced very well by the randomization from the two groups, open and laparoscopically. And what else you can see is that the outcomes are quite disappointing because laparoscopic was not better in any of these features than open surgery, laparoscopic Whipple as effective or as feasible as an open procedure, so no advantage. The only advantage that the colleagues found was a 1-day shorter hospital stay, which means you go home not after 21 days in China, but after 20 days. You can make up your mind yourself, I think, if this is a relevant difference for a pancreatic cancer patient having a Whipple procedure, leaving hospital 1 day earlier after laparoscopic resection or 1 day later after open resection. Just to put this in the context of the evidence we have for laparoscopic Whipples. For the robotic Whipples, we have no randomized controlled trials at the moment at all. 2 are going to be published soon. I will come back to that later. What about the surgeon? What does the robot and the training mean for the surgeon? I think the robot has the advantage that you can train this very well. And you see that when you train this, we have done this in my time in Heidelberg, when you have these training simulator skills for the robot, you have three groups of people, the complete beginners, the intermediate ones, and the experts in laparoscopic or open surgery. And they should train these robotic simulator skills. And looking at this, you see that the absolute beginners in some of the features do better than the so-called experts for open surgery as well as for laparoscopic surgery. This just tells you the robot has different skill requirements than open and laparoscopic surgery, and therefore also experienced pancreas surgeons must train with the robot before they start to do this. What is the reason for that? The reason for that is that the generation of surgeons that is starting now has been doing this in their childhood. We have been doing this. So they are simply more skilled with all of these things, and therefore they do better with the robot than somebody than me does it completely from the beginning. So you need a standardized training to have a good performance for the robot, and I think this is the big advantage. You can simulate this very well. You can learn with biotissue, and then you have these cadaver things, table assistance, and finally a dual console setup is the best thing you can do for training with the robot. What about the biotissue training? This is also something that should be implemented when you start doing these procedures. And once again, you can see what is the effect. This is an example where you can practice a pancreatic anastomosis with some printed 3D printing biotissue from silicone. And people like to do this. People are very keen on this. You can do this open, and you can as well do this with a robot and just simulate your anastomosis you need to do in the patient later on. When you do this, you see that after 5 attempts of performing any anastomosis of the Whipple procedure, the beginners get very much better, significantly better. They cannot reach the level of the experts in this, but they get better after 5 attempts, only 5 times training with the biotissue. And I think this is very important because this shortens your learning curve. The learning curve is something that is very essential as well. I just want to show you some aspects on this from the Pittsburgh group. They have analyzed this as one of the first groups in the world doing robotic Whipple procedures. And what you see is that they have cut-offs of 80 Whipple procedures to complete the learning curve. You must imagine one surgeon needs 80 Whipple procedures to complete his learning curve with a robot. This is probably something you can struggle with because you need a big caseload. You need to do this regularly to have these 80 robotic Whipple procedures, and then you have passed your learning curve and you do well. You see what the effect of the robot is. The robot is convenient. Pittsburgh started here, ended here, and by the same time they completely stopped laparoscopic Whipples because this is just painful. Everybody who has ever done a laparoscopic Whipple knows this. You do it like that for 10 hours in the robot, you can sit, and this is quite easy. And so for the surgeon, the robot offers much more convenience and a shorter learning curve probably than the laparoscopic, even if it is still a long learning curve. And I think this has to be also shown by this study. Robotic hysterectomies, different operation. What is the stress for the surgeon? They compared this robotically and conventional laparoscopy. Hysterectomy, standard operation in gynecology. And what you see is that with a robot, all your muscles are much less stressed than in the laparoscopic procedures because you, as I already mentioned, are very stressed when you stand there, when you have to take strange positions. With the robot, you can sit there relaxed. And this is shown very nicely in this study, and I think this is a big advantage for the surgeon too. What about the outcomes? I want to go through this very quickly. This is one of the most comprehensive analyses we have at the moment. Laparoscopic, robotic, open Whipple procedures, 4 RCTs, 23 other studies, 5,000 patients. Time and blood loss, of course, is better for the minimally invasive procedures you can see here. Largest literature is for the open, then comes the laparoscopic, then comes the robotic procedures. Just to explain this very briefly, what is shown in these plots. Blood loss, again, of course, is much better with the minimally invasive procedures. If you have bleeding, you just can't stop operating because you don't see anything anymore. Morbidity is more or less the same, so these procedures are surgically not dangerous for the patient, laparoscopic or robotically. Pancreas-specific morbidity, you also see, is about the same. Fistulas, bleeding, delayed gastric emptying might be a little better with the robot. And then radicality, very important for oncological patients, seems to be about the same as well. R0 resections and the harvested lymph nodes is also no difference between open, laparoscopic or robotic. What about more extended procedures, total pancreatectomies? We can do this with a robot or minimally invasive as well. This was some analysis that the Dutch colleagues just published this year, 16 centers, 360 total pancreatectomies, 100 out of them were done minimally invasive, as is shown here. And what you see is the criteria to select for minimally invasive. I already mentioned, you take the easy cases. And the biggest problem for doing minimally invasive is vascular invasion. This is when you choose open from the beginning. This is the criteria how the selection bias in the end comes to the end that I showed you before. Now when you look at this, you see this was matched afterwards, and these patients, of course, once again had a longer operative time for the minimally invasive procedures. Therefore, they had a little less blood loss, although this was not significant. You had same morbidity and mortality shown here. So again, minimally invasive is not dangerous for the patient. And you have the same rate of readmissions that is shown down here. And disappointingly, you have also the same length of hospital stay. So there is no big advantage for minimally invasive in terms of hospital stay, which is always the first thing people think of. Minimally invasive patient goes out day 3. Not proven by the literature at the moment. Another thing is that there were no restrictions in the indications regarding pancreatic cancer. So people also nowadays operate pancreatic cancer with the robot or laparoscopically. And again, you have the same kind of radicality here. R0 resections are the same. But what also can be seen here, again, the easier case is minimally invasive, more node-negative patients. And I think also very important, the minimally invasive procedures did not increase the rate of patients that have adjuvant therapy after the operation. So again, one of the big potential advantages, going home earlier, getting adjuvant therapy more often, is at the moment not proven by the literature. So there is, disappointingly again, no advantage for robotically or minimally invasive total pancreatectomy. So the advantages and the outcomes remain unclear at the moment. Maybe you have some advantages in the future when you only use the robot. These were also a lot of laparoscopic procedures included here. And again, to show you how these studies are selected, 3.7 years oncological survival in the minimally invasive group compared to 0.9 years in the open group. This is just an effect of more advanced tumors open and less advanced tumors minimally invasive. They do better, they do worse. Next, I want to just say one word of caution also with regard to the oncological outcome. And this is one of my favorite studies. They are not pancreas studies, and this is not a robotic study, but it's an extremely important study. Again, hysterectomy for early cervical stage cancer, a disease that can certainly be cured. This was traditionally operated open, then it started to become operated laparoscopically, and in the United States this was a very famous procedure for 15 years. Everybody wanted to have that. The first randomized controlled trial to be published on this procedure took 15 years, and after 15 years of practicing, you see that the oncological outcome is significantly worse for the minimally invasive hysterectomies compared for the open hysterectomies. Why? Because you have early local failure, which finally means early tumor persistence, probably because the operation was just not radical enough. And this is something you have to keep in mind when we do robotic approaches. Are we radical? Are we not? We have to evaluate this, and we have to create good randomized controlled trials. We can be radical. I will show you some videos in a later session, and we can remove everything around the vessels, the triangle operation we have called that, also with the robot, not only open. You see, also with the robot, you can approach the mesenteric vessels, you can take away all the lymphatic tissues, all the nerves here, and finally, you can have a oncologically clean situation with this triangle between SMA portal vein and celiac axis, as we know this from open surgery. Final aspect I want to mention briefly is the money. This is something you have to keep in mind as well for the robot. Some study from the US comparing open and robotic Whipple again with cost analysis as the main focus. What you see is the robot is definitely much more expensive than the open procedures, and this is not related to some increased morbidity. The money that is put in the robot you lose in the OR. This means for all the devices you need, for all the dressings, for all the devices you have to buy from the company. This is significantly much more expensive than doing this open. This might be feasible in the US when you have a private insurance. These insurance companies cover your robotic costs 100%. If you are unlucky and you don't have a private insurance, the insurance companies cover 0%. In Germany, they cover 0%. Every robotic Whipple I do in my hospital is $2,000 on the hospital in excess to the regular costs. So this is something, please keep that in mind. We have to do this, but we have to be aware of this. Why is there so much pressure in the robot? Because the industry is pushing. You have 6,000 Da Vinci systems around the world at the moment. Every 25 seconds, any surgeon around the world starts a Da Vinci procedure. And the gross market of Intuitive is projected to be about $14 billion in 2028. So you can imagine how this company comes to you and says, oh, do it with a robot, that's nice. Certainly it has advantages, but we don't know these advantages really with evidence at the moment. At the moment, there are 2 RCTs published on robotic procedures of the pancreas. They cover some very little aspects that are not important, and 3 study protocols that are really important on the robotic Whipple versus the open Whipple. And exactly this Europa trial we performed by my time in Heidelberg is finished now. We will hopefully publish it end of the year. And the Dutch trial is also finished, so there will be some better evidence in the next 2 or 3 years when we talk about robotic Whipple procedures. So from my point of view, the robot is definitely here to stay. We will work with the robot in the future. There are possible advantages. We have not proven them yet. Cost negotiations are, especially in the DRG countries, extremely important, and we need independent evidence to finally prove and not to make the mistake that I showed you for the minimally invasive hysterectomy and realize after 15 years we do oncologically worse just by using a fancy tool as the robot. Thank you very much.